almost noon. The good thing is I don't have that many slides, so we'll be done by 12. Um, so for folks that don't know me, my name is Rif El Mallakh. I'm one of the faculty members here, and I've actually been at University of Louisville since 1992. So I'm actually been here a little bit longer than you guys have been alive, or some of you. But it's when this slot came available, I requested to present because we got some interesting data, and I wanted to talk about it. And I just thought it might be interesting to talk about it here. I'm going to be talking about really the effect of alcohol in a model specifically that we have in our lab. But before I do that, I'm going to talk a little bit about the whole problem with comorbidity of alcohol abuse in people with bipolar illness. And really, it is a significant problem. I do have some disclosures in terms of, oh, didn't save. In terms of companies, and I did already present the outline. So we'll start with really the whole relationship between alcohol and bipolar illness. This is a long relationship. So this is in the early 1900s, but I bet it has extended even earlier than this. This is from Kreplin, believing that alcoholism occurs really as part of the illness, as opposed to that their behaviors are related to the alcoholism. So he thought that there was a fairly specific, that alcoholism itself in bipolar patient was actually a characteristic of bipolar illness. And, we call it comorbidity. And I think that's a more reasonable thing. And I'll explain why in a minute. So it's very clear, though, that alcohol abuse stands out as being something that is, I'm not going to say uniquely, but has a special relationship with bipolar illness. We're talking, I'll show you several studies, and the numbers will be different in all of the studies, but we're talking about studies where it doesn't matter ultimately what the absolute number is. In here for bipolar 1, it's 45%. In every single study, the relationship with alcohol and bipolar illness is higher than in any other psychiatric illness. And this just shows you type 1 and type 2. The next closely related disease is schizophrenia, where it goes up to like 32, 33%. So we're talking again about 10% difference between type 1 and the next thing down. Certainly, men are way more likely to abuse alcohol with bipolar illness, but this has to do with the whole relationship between alcohol and gender in our society. So even 29% is something like 4 or 5 times the rate of alcohol abuse in the population. So even when you see a gender difference, it's the actual relationship is not different. Alcohol has a relationship. And this is another study, or this is a review from the Goodwin and Jameson textbook about bipolar illness, combining a bunch of studies. But what you see here is if you look at folks that have no alcohol and just substances, we're talking about less than 10% of patients. Even if there are other drugs like cocaine or cannabis, there's alcohol. And when you look at all of those things together, again, there's a special relationship with alcohol. This is from the National Comorbidity Survey, and this is a study that was done twice. It served a long time ago. There was the epidemiologic catchment area. This is the follow-up of the epidemiologic catchment area. The idea with these studies is they're done in the community. So up until now, all the studies I've shown you are studies where people are coming in for treatment. And, you know, that's maybe a little bit selected. So when you go into the community and just knock on doors and say, you know, we'd like you to sit down with you for about 4 hours and ask you very intimate questions, some people actually say, sure, come on in. So these are all studies that are done literally in the community and almost the way I described it. And these are large studies. So I think the sample size that came up with these numbers were 4,000 interviews across the nation. And what you see in the substance is down here. Alcohol dependence, 61%. Very similar to the numbers we've been seeing before, but here it's more than half, 61%. Again, drug dependence can be up to 40%, but any substance use, 70%. What that means is, again, if you look at the 60% in any substance use, the difference is 10%. So a lot of these folks that have drug dependence also have alcohol. So the difference, again, if a patient comes to you and says, I have bipolar illness, and by the way, I also misuse drugs, but I don't misuse alcohol, it's unlikely, actually, that patient has bipolar illness, because the majority of patients that have bipolar illness and a substance problem, that substance problem will include alcohol. So if it's, I don't ever use alcohol, but I use cocaine, or I use amphetamine, or I use pain medicines, that's possible in 10% of the patients. So it's, again, the point I'm trying to make is that there's a specific relationship between alcohol and bipolar illness. So the question is, why? Well, so I'm going to answer that question the long way around. This is actually a study that was done by Dr. Stewart, who's here. And it's actually where, again, this whole thing of, this takes us back to the Kreplin quote, right? When you see somebody who has symptoms of bipolar illness and is also misusing substances, how do you make the diagnosis of bipolar illness? And unfortunately, this is an editorial, and I may be wrong, but unfortunately, in today's environment, for us to get actually to be able to get treatment for some of our patients, or to be able to be reimbursed for some of our patients, we have to give them a primary psychiatric diagnosis. You can't admit somebody, for example, in the hospital if they're using cocaine just for the cocaine. You have to give them a primary psychiatric diagnosis. So, when they were using the cocaine, they were prostituting, they were doing all sorts of things, they didn't sleep for several days, they must have had bipolar illness. So it's easy to give these individuals a bipolar diagnosis in addition to the drug use. So this study was actually done at the Healing Place, where people specifically came in for treatment of their drug use. And at the same time, they said, well, while I'm here, I also want to make sure that my bipolar illness gets addressed. And when we sat these people down, or actually when Dr. Stewart sat these people down and went through a diagnostic interview, did the SCID with them, In a lot of these patients got the medical records. Most of these folks had a bipolar diagnosis that was actually given by a psychiatrist, usually for an inpatient stay. When we got these medical records, went through the entire history, it was clear that in about 60% of the patients that they did not meet criteria for bipolar illness. Only about 42, 43% actually met criteria for bipolar illness. So the majority of folks that were coming into this program saying I have bipolar illness and a substance problem, had a substance problem, but didn't meet criteria for bipolar illness. This study actually, by the way, was replicated in New York, where in New York, it was 70% of the patients didn't meet criteria for bipolar illness. So we misdiagnose, we know that there's a relationship, and we misdiagnose the two. And I am, again, just again as an editorial, not necessarily as an absolute thing. If there is no alcohol abuse, it's unlikely to be bipolar illness. It's just the most common one. If you just play the numbers, there has to be alcohol abuse. But here's the problem. There is potentially a real relationship between the two. That is, of course, in some of the psychological literature, the self-medication issue, and I'll talk a little bit about that. But it doesn't take very long, even if it doesn't matter what illness if I have anxiety and I like to drink because it makes me less anxious. If I have bipolar illness and I like to drink because it controls my symptoms, it doesn't matter what the illness is. Very, very quickly, alcohol abuse becomes its own disorder. And I'll show you the data that that's clearly the case in people with bipolar illness at the biologic level. But there may be an association. That is, we a lot of times talk about self-medication, and I think that we actually have data that suggests that this might be true for bipolar illness. But very, very quickly, alcohol misuse becomes its own disorder. And as such, self-medication, if alcohol indeed was self-medication, you wouldn't have an increase in ER visits because you're drinking, right? You wouldn't have an increase in hospitalizations because you're drinking. So this whole idea that substances are self-medication may have some validity, but very, very quickly the substance becomes its own disorder, and you see the problems related to that particular disorder. This is just a more laborious way of saying the same thing, that it becomes its own disorder. So within 6 months, 50% of the patients have resumed drinking. Within 6 months, the likelihood of a person with bipolar type 1 illness to have had a recurrence is quite low, less than 10%. And so the numbers here, again, don't jive. Within 6 months, they start drinking again. This is related, again, to alcohol misuse becoming its own condition. But this whole idea that substance use may have its roots in psychiatric symptoms is not unreasonable. Again, this whole idea of the self-medication hypothesis. And people that know me know that I rail against the self-medication hypothesis because it really ultimately gets in the way of getting treatment for your substance use, right? Because almost all these patients that might have true dual diagnosis or might be misusing the drug for a true psychiatric condition, almost always say, treat my psychiatric condition and I'll stop using the substances. And of course, because the substance becomes its own disorder, you can't do that. It's not successful. You have to treat both. So Okay, so how do you test the self-medication hypothesis? You know, the self-medication hypothesis has been around 2 or 3 generations. It's been here with us for a while, and we have no evidence that it's real, right? So we have a hypothesis that sort of makes sense, that's certainly perpetuated by the patients themselves, but we don't actually have any objective evidence that it is real. So how do you actually test it? Well, you need a model that you can manipulate. You need a model that has the genetic heritage of the disease. And you need a model that ultimately is separated from the patient's subjective descriptions of the substance, right? So you know, certainly when I drink, I feel better, I feel calmer. So I'm not going to talk about alcohol as a bad thing, right? So you need to, if you're going to ever be able to understand really, does the self-medication hypothesis make sense, you need to separate it from the subjective experience. And so what we did in the lab is we went ahead and used our cellular model for bipolar illness. And let me describe that a little bit. So in a lot of conditions now, people want to study things at the cellular level. But again, when you study things at the cellular level, you want to actually have the genetic heritage of the condition. So the majority of researchers have solved that problem with something called induced pluripotent stem cells. People heard about induced pluripotent stem cells? So it's for folks that don't know what those are, it's actually a simple idea, although a little bit more complex to actually go through. It's a fairly labor-intensive procedure, but all you have to do is you get a mature cell. It doesn't matter where. Most of the time, the source of mature cells in these models is fibroblasts. So you do a skin biopsy. So you just do a simple skin biopsy. You get these cells, grow the fibroblasts in culture. Now you can get primary culture going for a few weeks before the cells will die. But before they start aging and dying, you infect them with actually 3 genes, 3 master genes. These master genes, what they do is they switch on and switch off genes that regulate development and essentially convert this mature fibroblast back into a stem cell, back into essentially an embryologic cell that has the potential of becoming anything. And not just the potential of becoming anything, it's now a stem cell, so it's actually immortal. So you take a cell that was, if you had kept it in culture for another 2 weeks, would have died. You just give it human genes, by the way. These are 3 human genes. Give it 3 human genes and it becomes immortal and becomes able to generate anything you want. And now you can treat it with usually genes, although you can also use chemicals to make it mature into something. So let's say we want to study neurons. You take this induced pluripotent stem cell. So now it's a stem cell again. And you treat it with, say, infected with a couple of genes, and it matures into, say, a dopaminergic neuron or a glial cell. I mean, you can do a lot of different things with these. But there's a problem with these induced pluripotent stem cells, which is how you got them in the first place, right? So you took these cells, and even though they were cells from a patient, so they had the genetic heritage of the disease, you went in and you infected these cells with 3 master genes. So a master gene is a gene that actually doesn't necessarily make a specific well, does make a specific protein, but doesn't make like a membrane protein or it makes a protein that goes around and affects multiple other genes. And so with these 3 genes that you've infected into the cell, you've actually altered the expression of about 400 or 500 genes. And that's how the cell becomes an immature stem cell in the first place. And so what you've done is you've gone out of your way to get a cell that has the genetic heritage of the disease, and then you took that away. You just said, okay, I'm going to change the expression of all 500 genes in the cell, and that's going to teach me something about the illness. Well, maybe not. So what you really need is you need an unaltered cell. And this is the beauty of these cells. So these are olfactory neuroepithelial cells. So they're at the roof of our nose. They're the cells that allow us to be able to smell things in the world. And we can get a biopsy of them. They're right up at the roof of the nose. We can get a biopsy of them. And in the biopsy, we hope that we include a progenitor cell. So a progenitor cell is simply a cell that already exists in our olfactory neuroepithelium. And its job is to replace cells that are going to die in our olfactory neuroepithelium. So we can't live a lifetime with the original cells that were formed either in utero in our first year of life, whenever these cells mature. They don't live a lifetime. The roof of our nose is a horribly hostile environment, and our cells die fairly readily there. And they have to be replaced routinely, and they're replaced because by these cells, they're called progenitor cells, that simply divide, and they'll make support cells like glia, they'll make neurons and olfactory neuroepithelium. So these are cells that already live there, and we just have to actually make sure that the biopsy includes that. And this is just to show you that even though we're taking a piece of the olfactory neuroepithelium out, there isn't destruction of the ability to smell. It stays the same. But we grow the cells. Dr. Roizen actually developed this method. Here he is with one of his subjects, and he was doing these experiments because he wanted to use these cells to fix spinal cord injury. And that rat, by the way, that he is walking across a tightrope, pretty big tightrope, but still you need a lot of balance and coordination to do that. That rat has a spinal injury, so that's been fixed with these cells. But what you do is you take the biopsy, you grow the biopsy, and if one of these progenitor cells is in there, in about a month, maybe 2, it'll start developing these things called neurospheres. So it'll grow into a ball. And these are essentially progenitor cells that are dividing faster than the rest of the culture, which isn't dividing at all because these are primary cultures. So they're dividing, and because they're dividing so fast, they don't actually grow flat, they grow into a ball. And once you discover these, you can actually pull these and you can grow them, and they will on their own differentiate into neurons or into glia or stay undifferentiated. So these cultures that we use contain a heterogeneous population of cells that have already differentiated or are immature, but they are cells that have not been altered in any way. But because we've obtained cells from people with bipolar illness and matched controls, these cells have the genetic heritage of the disease. And so now that you have the cells, how are you actually going to model the disease? And so we've modeled the disease by picking on sodium, because we know, and actually way back from the 1960s, the top right graph here, we know that intracellular sodium is increased in patients who are manic and patients who have bipolar illness and are depressed compared to normal controls. So this is whole body sodium measurements, but there's clear elevation over twice the amount of intracellular sodium in cells in intracellular compartment in patients who are actively ill, whether they're manic or depressed. And we've actually tested this in some of our lymphoblasts. So lymphoblasts are, again, cells that are from patients. In this particular case, they're blasts, so they've actually been infected with an Epstein-Barr virus, which may change things. But in this particular case, again, bipolar patients on the right, controls on the left, you can see that the intracellular sodium concentration in these cells is elevated compared to controls. The reason for this involves several things. It might, well, this is just in red cells. So in living patients, this is another way of looking at this. In living patients, sodium pump activity, and this is in red cells, is reduced in manic patients compared to euthymic patients. It's reduced in depressed patients compared to euthymic patients, but it's no different in manic or depressed patients compared to controls. So there's a deviation from the patient's own normal. It's within the entire range of normal, but it's a deviation from the patient's own baseline. If you actually stress these cells, if you actually treat them with a drug that increases intracellular sodium, and these are old experiments, so in those experiments we are using ethacronic acid, which is an old diuretic. If you actually stress these cells and increase intracellular sodium, they're unable to respond. So sodium goes up, sodium pump activity does not go up, expression of sodium pump does not go up compared to controls. Patients who don't have bipolar illness are able to increase sodium pump activity, sodium pump expression, and normalize intracellular sodium and calcium, but people with bipolar illness are unable to do that. And some of that, actually, this inability to respond to ethacronic acid or alcohol, by the way, may be diagnostic. So this is actually a company called Psychnostics, which has done experiments that suggest that you can use the inability of white cells to respond to an increased intracellular sodium as a diagnostic procedure. One of the things we're looking at is whether a hormone, endogenous cardenolides, is the reason for this. And we have some evidence for this. So endogenous cardenolides really are chemicals that we make in our body that are just the same as the chemicals that come from plants. So I don't have foxglove on here, which is, of course, the source of digoxin, but we do have digoxin-like compounds. I have the wabia plant, which is the source of wabane. And the reason I put the wabia plant on there, it's an African bush. The reason I put that on there is because it's the wabane-like compound that appears to be most different in people with bipolar illness. And when you measure this, people who are actively ill have less of these compounds than normal controls. This is a small enough sample that we can't see a difference between people who are actively ill and euthymic patients. But euthymic patients are tricky, right? Because you can be euthymic, meaning you're having very few symptoms, But that doesn't necessarily mean that your physiology is euthymic. It only means that you're not expressing the symptoms. And a lot of our medicines simply control the symptoms without actually affecting the disease. And you can get a feel for that by looking at the variance in the euthymic folks. Look at how tight, these are standard deviations. Look at how tight they are in patients who are sick or in controls, and just how all over the place they are in people who are euthymic. So euthymic, it's a difficult state to actually test. People who are euthymic may not actually be euthymic if they're on medications. But at any rate, we know that there's that when we actually measure endogenous wabane in your system, that because it is summer right now, it's actually fairly high. There seems to be a variation where in the winter months it's low, and in spring, summer, and fall, it's higher. But that variation doesn't seem to occur in people who have bipolar illness. They seem to just not change throughout the entire year. What's really interesting is their most normal time is winter, which is actually the time that people with bipolar illness are most stable. So people with bipolar illness are least likely to get manic or depressed during the winter months. And that's the time that their endogenous wabane is actually in the normal range. And you can actually take any human being, and well, I shouldn't say that, any human being that doesn't have bipolar illness, and put them on a treadmill, exercise them until they're exhausted, and show that the body, one of the things that the body does to deal with this is to make more of these endogenous wabane compounds, but that doesn't happen in people with bipolar illness. So at baseline, actually, because this study was done throughout the entire year, so on the average, at baseline, people with bipolar illness actually were different than normal controls. But then when we took people and exercised them till exhaustion, and this is till exhaustion, until they couldn't go anymore, people who don't have bipolar illness, controls, who are not athletes, increase their wabane-like factor, OLF production, but people with bipolar illness were just plain old flat. They just aren't able to do that. One of the connections that I think, and we haven't done this study, and the only reason I actually have this slide is to ask for volunteers. One of the connections that I think this OLF wabane-like factor in bipolar illness happens is in sleep deprivation. You take a person with bipolar illness, you sleep deprive them, they get sick. Because sleep deprivation, as these animals have taught us, is associated with an increase. If you are, in this case, these are normal animals. If you don't have bipolar illness and you're sleep deprived, natural physiology is that you make more of these compounds. I think people with bipolar illness are unable to make more of these compounds, and so you put them in a stressor where they need to make more of this compound. They don't. Their intracellular sodium goes up, and they get sick. Okay. So what we decided to do was take these cells and treat them with glutamate. We actually use MSG, and we just treat them with glutamate. And the idea is, of course, these cells will increase intracellular sodium, just like what happens in intracellular. I showed you the data from the 1960s, just like what happens to people with bipolar illness. Sodium goes up, and we know that glutamate has a role. So we take these cells and we essentially model mania in these cells. And we know that because the intracellular sodium goes up. So we have now manic cells in culture. So we take these manic cells and we do lots of things to them. So we treat them with glutamate. And so these are the controls. And all of these numbers, by the way, are expressed as percent of controls. So the control is simply 1, okay? And when you treat the cells with glutamate, sodium goes up. It actually goes up in both controls and in bipolar patients. If you treat the cells with just alcohol, and this is alcohol for 6 hours, intracellular sodium goes up to the same degree that glutamate goes up. Now, what's really interesting here, of course, is the amount of alcohol we used is about what you would get if you were a serious drinker, about 350 0.35 milligrams per ml, per DL. And so this is pretty reasonable. This is a clinical alcohol level, if you will. And if the cells are treated with just alcohol, they do exactly the same thing that glutamate does. And this is what I'm saying, that alcohol use, if you're euthymic and you drink alcohol, it's no different than if you, say, have so much glutamate that you're manic. Lithium alone doesn't change anything. When you're measuring intracellular, lithium only reduces elevated sodium. It doesn't lower sodium in normal cells. And we've shown that before, and this is just a replication in a different type of cell. Now, when you treat these cells with lithium and glutamate, so now you've modeled mania in these cells, and you say, okay, I'm gonna start lithium, treat you with lithium, and you give them a therapeutic level of lithium. We put in 1 millimole of lithium, 1 milliequivalent per liter, essentially. This is very interesting. You normalize intracellular sodium, but only in people with bipolar illness. The cells from normal controls, now all of these cells still have glutamate swimming around. The cells from normal controls continue to have the glutamate effect. Lithium only works in terms of normalization of elevated intracellular sodium caused by glutamate, only works in people with bipolar illness. So that in itself is very interesting. When you treat the cells with this amount of alcohol that makes people pretty drunk, the effect is exactly the same. Alcohol normalizes intracellular sodium, but only in cells obtained from people with bipolar illness, doesn't do that in cells obtained from controls. So the huge jump between a cell growing in culture and your patient walking into your office, huge jump, is that when they drink when they're manic, they actually are better clinically. When they drink, where did it go? When they drink when they're euthymic, they actually get sick. So alcohol is its own disease. It may indeed help improve symptoms. And of course, it's been happening ever since alcohol existed at a much higher rate in people with bipolar illness than in the general population. It may indeed help people have fewer symptoms when they're manic. Actually, almost to the same degree as lithium. But if they drink alcohol when they're well, they will get sick. I think this is very interesting. And actually, Dr. Wright thought it was very interesting. One of the cool things that Dr. Wright has done is that he's been squirreling away his own money in a fund here at the University of Louisville to create a research fund. And we were lucky enough to be able to submit a proposal for this, and we got the second grant that Dr. Wright has been able to fund here at the University of Louisville. So it's so thank you, Dr. Wright. But with that, I just really summarize this whole idea that increased intracellular sodium, and people have heard me talk about this, and it's, of course, there are lots and lots and lots of indirect bits of evidence that increased intracellular sodium is clearly a problem in bipolar patients. All of our mood stabilizing treatments lower intracellular sodium. That is what we do when we give somebody an anti-seizure medicine or lithium. All of our treatments lower intracellular sodium. This is a very important central characteristic in bipolar patients. Modeling it in cells obtained from bipolar patients is quite a reasonable way of trying to model mania in this type of model. Using this model, you can actually show that alcohol makes these cells sick, in quotations, and that lithium normalizes intracellular sodium in the same way that alcohol normalizes intracellular sodium. Not just that it normalizes it, but that that effect is unique to cells obtained from people with bipolar illness. So, not quite 12 o'clock, but almost. Any questions that people may have? Yes? No. That's a good no. The only thing that the controls were excluded from is having bipolar illness. The controls were all surgical patients that came in and they were having an ENT procedure, and we just got a sample of their olfactory neuroepithelium. Oh, we're in the neighborhood. You don't mind if we just take a little piece of tissue? Oh no, take as much as you want. So they were they were just non-bipolar. You know, that may very well be a good experiment to do. But you know, maybe Dr. Stewart can tell me, can you find somebody whose only diagnosis is alcohol dependence without, say, an anxiety disorder or without a mood disorder? I mean, I know you can't find anybody with a substance problem without PTSD. I'm exaggerating, of course. It would be a difficult population to collect. The patients with bipolar illness had all of them had previous alcohol problems. None of them were using alcohol within years of when they gave us the samples, but all had alcohol problems at some point in their lives. Yes. Alcohol is an anticonvulsant at therapeutic doses. It becomes a proconvulsant, of course, at high doses. But so do anti-seizure medicines. All of the anticonvulsants that have been demonstrated to have a mood stabilizing effect inhibit the sodium channel in an activity-dependent manner. I'm not sure I understand your comment, please. Right. That's a very good, the answer is clinical. We know that that's not the case because we have placebo-controlled studies looking at relapse prevention. So, but that's a very good question. So I don't think so because of how these medicines work. Both lithium and anti-seizure medicines inhibit the sodium entry in an activity-dependent manner. So you saw, this is just for lithium, but you saw that lithium alone had no effect. And so that's because the cells weren't abnormal. When the cells are made abnormal, lithium normalizes the intracellular sodium. And so because of how they work, because they only work in abnormal cells, it's an activity-dependent phenomena. By abnormal cells, I mean cells that are firing very, very frequently, more frequently than normal cells. You're essentially giving it at a disruptive dose. And the cells have to become abnormal, and at that dose, it prevents the abnormal cells from being abnormal. But because it's a sub-disruptive dose, it doesn't. And that's why, of course, with toxicity, you get all sorts of problems, including seizures, but because you're doing it at a sub-disruptive dose. Yes, I'm sorry. Yeah, I mean, it's exactly the same effect as far as intracellular sodium is concerned. I'm sorry, Steve. I remember very well. Yeah. Thankfully, well, it still is the case at Women's Healing Place, but most of the other places, it's not as much of an issue. Ben? We picked a dose of alcohol that we thought was clinically relevant. One of the problems when you treat the cells with alcohol is alcohol evaporates really fast. We're treating them for 6 hours, but by the end of the 6 hours, the level of alcohol has dropped, at least in the media. It may still be in the air around the cells, but it evaporates fairly quickly. So we wanted a clinically relevant concentration, but not one essentially where the alcohol vanishes really quickly. And so we didn't study lower concentrations. Yes. Well, that's what we're measuring. We're measuring intracellular sodium. And we're comparing it with a drug that we know reduces intracellular sodium in cells that have elevated intracellular sodium. So the question really is, well, what's the mechanism? What's the shared mechanism between alcohol and lithium? in terms of correcting this. And if we find that shared mechanism, will that actually teach us anything about either alcoholism or bipolar illness? And that's exactly what Jess's grant is going to help us do. We're going to be looking at predominantly glutamate because we think, I mean, these cells are being treated with glutamate, so we're looking at the NMDA receptor. Alcohol probably increases intracellular chloride, but in these cells it also reduces intracellular sodium. So if you just think of alcohol as increasing intracellular chloride, we didn't measure that, and you wouldn't necessarily expect a reduction in intracellular sodium. So that's why we're focusing on the NMDA receptor. But yeah, I mean, you're absolutely right. That's the next step, is to figure out the mechanism. Not at rest. Lithium doesn't change intracellular ions if the cell is not disrupted. Yes, please. Go ahead. Yeah, this is actually something that has been, so the question has to do with why would an increase of intracellular sodium make you sick? And there's several reasons. The major thing is we know that the elevation, the intracellular elevation is right around 10 millimoles. In neurons, the intracellular concentration of sodium of a neuron at rest is right around 10 millimole. And if you double that, you're at about 20 millimole. And we know that that's what happens. I mean, these are measurements that have been made. When you do that, your resting potential is closer to the threshold potential. The threshold potential doesn't change. Threshold potential is fixed. But if you depolarize the cell at rest, the resting potential is closer to the threshold potential. Now these cells are easier to stimulate. So if you think of almost every manic symptom, really are cells that are firing when they shouldn't. You have looseness of associations. These are cells that shouldn't be firing. They should be quiet, but their resting potential is too close to threshold. So if they get a little bit of stimulation, off they go. When you think about increased activity, when you think about almost anything that involves mania, it involves cells that are easier to depolarize. So it's really easy to imagine that the major thing that happens in bipolar patients is that there's a slight increase in intracellular sodium, and it's relatively slight. It's only 10 millimoles. That has no effect on your muscle. That has no effect on your kidney function. It has no effect on your blood pressure. It's slight enough that only neurons, which really depend on that difference to control function, where it actually shows itself. If you depolarize the cells some more, say, take them up to 30 millimoles, now some of the cells will actually be in depolarization block. And you can now easily imagine depression, right? At least the depression, talking about being a dinosaur, the depression that we used to call depression before just a patient coming in and says, I feel down, becomes depression. In the olden days, depression was really a disease. People were essentially paralyzed. They couldn't get up, they couldn't think, they had psychomotor slowing, the way they walked was different. People had to be really sick. And if you have some of your neurons, just a small fraction of your neurons in depolarization block, that's what you'd look like. If you continue that process and increase the number of neurons in depolarization block, you will have catatonia. And lots of people that really are interested in understanding catatonia believe that catatonia has nothing to do with schizophrenia. It is the most severe manifestation of a bipolar illness. And of course, the number one prophylactic treatment for catatonia is lithium, in addition to using drugs that hyperpolarize the membrane, benzos. And so this is really fairly easy to see that just an increase in intracellular sodium, just the inability to modulate sodium transport across the membrane, during situations where that's important, if your physiology is not allowing you to adapt to situations where you need to increase your sodium pump activity, you can very easily imagine bipolar illness developing. About 75% of genes identified as having something to do with bipolar illness are genes related to ion regulation. So this whole issue of ion dysregulation is actually fairly important in understanding the pathophysiology of bipolar illness. And of course, that's the reason that the most specific treatments for bipolar illness specifically focus on ion control and specifically focus on sodium. I mean, I bet it would work. Based on this, I bet it would work. Yes. Yeah, so what's interesting, I showed you the Psychnostics company, and they were copying our experiments. We had used the ethacrynic acid. And one of the interesting things, and we did the ethacrynic acid experiments in lymphoblasts, so not in neurons, but ethacrynic acid is not water soluble. And so we actually dissolve ethacrynic acid in alcohol. And so what the Psychnostics folks have learned is they don't actually have to treat the cells with ethacrynic acid. They simply treat them with alcohol. They treat them with the thing that we use to dissolve the ethacrynic acid. So some of the earlier experiments may not. It's a complication of interpretation of those data. Well, thank you guys for your attention.